I apologize if I stole any of your guys' ones because I forgot which ones I had signed, so I did like a bunch. Did anyone have the mitral commiseral view? No?
Nope,
Oh, all right, good.
all you, Dan.
All me. All righty. So in this view, we visualize the left atrium, the left ventricle. So this view is one of our primary views for assessing the mitral valve leaflets, as well as also assessing the papillary muscles. We get a good view of both the posterior medial papillary muscle, as well as the anterolateral papillary muscle. So I labeled my valves, our posterior mitral valve leaflet. We have our anterior mitral valve leaflet. So this is also one of our mid-esophageal views. So a fairly large percentage of our views are going to come from that mid-esophageal level. So the mitral commiseral view, the angle for this one is between 50 and 70 degrees. I also did the two-chamber view from the mid-esophageal level. I wasn't sure if I stole that from someone too, but does anyone have the two-chamber view?
No,
All right, good. So again, this is another mid-esophageal level view for our two-chamber. So with this one, we get a very good view at our posterior medial papillary muscle. The reason that's also important is because this is the one that will tend to rupture more often, this posterior medial papillary muscle. So if we're have any concern with issue for papillary muscle rupture, this two-chamber view at the mid-esophageal level will give us a good view of that. So we have our left ventricle, left atrium. We see a portion of the left atrial appendage in this view, but not in its entirety. Again, so this is our posterior medial papillary muscle. We could see, well, the posterior mitral valve leaflet. You also visualize the anterior mitral valve leaflet. We can also visualize the chordae in this view as well. So if we're worried about chordae rupture as well. So this one is going to be also the mid-esophageal level. And this one has an angle of 80 degrees to 100 degrees. So it's kind of an extension or a continuation of our rotation from our mitral commiseral. So we're rotating a little bit more to an angle of 80 to 100 degrees. And we're now kind of angling more out to the posterior aspect of the heart. So we're able to visualize that posterior papillary muscle, posterior medial papillary muscle. Gave this guy LVH. So now we extend our camera a little deeper into the esophagus, and we're actually entering into the stomach, essentially. That's how these views get their name, transgastric, because we've now passed the esophagus and we're now entering into the proximal portion of the stomach. So these now become our transgastric views. So the important thing to remember with transgastric views, the transgastric views are going to give us a very good assessment of systolic function. So your short axis views from the transgastric level, you're going to get those nice wall motion to assess wall motion and systolic function from here. So your short axis views from transgastric, you get your papillary muscle level, you can get your apical level going deep gastric. So if you want to go all the way down to the apex, you really have to extend it into the deep gastric level. Your mid-level would be your papillary muscles, and a little more proximal in the transgastric is going to be your basal short axis view. So basal, base of the heart. In this short axis view, we're able to visualize our mitral valve. So we have our interventricular septum, right ventricle. So this is going to be your anterior mitral valve leaflet and your posterior mitral valve leaflet. So you kind of also have to train your eye and realize like how the view is going to be. So if we're coming down the esophagus, we're angling back up at it. So now this is going to be more anterior and this is going to be more posterior. So better appreciation is if we go deeper down here to your transgastric, you're going to see your left ventricle first and your right ventricle is going to be kind of off the screen when we would view it.
Can you
Like,
tilt your
I-
camera just a little more for
Oh,
that
sure,
one?
Sure. So
That's
like,
perfect.
so when we're deep gastric, we're really like kind of following the esophagus down and we're kind of angling back up at it at the heart from this angle. So, you know, this is the top of our camera. So the first thing we're hitting is the left ventricle and then the aorta, like, you know, coming off the top of the heart. So that's going to be on our far field, in our far view, the left atria. So I'm kind of, you know, visualizing the camera down in this view. So just kind of getting an understanding of your probe position, like with relation, with relation to the heart, your transesophageal echocardiogram may help you to kind of, you know, decipher some of these images and what you're seeing. So, like if that's like, you know, our the top of our transducer. So like if I'm kind of visualizing my heart sitting there and like we're coming down, you know, like down the esophagus and we're angling back up at it like that, like getting into the stomach, you know, I'm going to hit that left ventricle first and we're angling back up at it. So like in our far field, it's going to be our, you know, aorta and left atrium. So if you kind of just think of the probe, where the probe is in relation, you know, to your picture, it might help you on the boards to kind of decipher and break down these views. So for deep gastric long axis view, so this we're extending deeper into the stomach, advancing the camera further. The transgastric long axis view, the deep gastric view, has an angle of 0 to 20 degrees. In this one, we visualize the aorta, the aortic valve, left atria. So we can see our posterior mitral valve leaflet, anterior mitral valve leaflet, and we see a segment of the right ventricle as well. So this is the interventricular septum. And I did also this RV inflow outflow view. So then now this is coming back up. So we're now back up in the mid esophageal level. So this is a good view for us to be able to view the right ventricular outflow tract. So we see the right atrium. We're able to visualize the tricuspid valve, a portion of the left ventricle, but the real focus is being able to see the inflow as well as the outflow in one view. So we're able to see the right ventricular inflow through the tricuspid valve, and we also see the RVOT and pulmonic valve in the outflow tract. So in the center of that view, we have a transverse view of our aorta. It's almost at the aortic valve leaflet level, but you don't actually see the actual leaflet cuffs. You also see a segment of the left atrium and the left intraatrial septum. So this RV inflow outflow view is going to be mid-esophageal. with an angle of 50 to 70 degrees. Then I also did this aortic valve long axis view. So again, this is another mid-esophageal view. This one has an angle of 120 to 140 degrees. So this view is actually good for assessing all three leaflets for the aortic valve. So we can, your best assessment for any aortic valve is going to be your short axis view. But we can also get a good assessment of those leaflets as well in this long axis view. So with this view, we have our left atrium. We can appreciate our posterior mitral valve leaflet, our anterior mitral valve leaflet. We also see our LVOT. So I like these views because you can also get a pretty good appreciation of why we have SAM, systolic anterior motion of that mitral valve leaflet. You can really appreciate the proximity of that leaflet to that LVOT and like how easily that leaflet could get sucked into that LVOT when we have an LVOT obstruction and elevated velocities in that LVOT. You see the leaflet sitting right there. In terms of our aortic valve cuffs in this view, so we have our right ventricle that we also visualize in the image. So the more inferior cusp is going to be our right coronary cusp. And the one close to the mitral valve, the more anterior cusp, it can either be the non-coronary cusp or the left coronary cusp. We're able to actually angle the probe slightly and visualize either one of them. So if we angle more to the left, we're able to visualize the left coronary cusp from this view, or we can also visualize the non-coronary cusp. But just remember that this posterior one is going to be your right coronary cusp. Yeah, so slight angulations, you'd be able to visualize the non-coronary or the left coronary. And you also visualize the right coronary cusp from that view. Who wants to
Cool.
be next and show us your pretty pictures?
I can go, but mine is not going to be as good an explanation as yours.
That's all right. We'll explain together.
Okay. I'm going to share my screen because
Sure.
how do I do that?
Remember, this is being recorded forever.
How do you share? Oh, here, I see it.
Oh, do I need to let you share? Share screen, only all participants. All right, go. You can share.
Okay.
Nice.
Um,
Oh, yours are pretty, like really accurate.
okay. So my first one was mid-esophageal, long axis, and the angle is 120 to 160. So you can see the left atrium. Can you see my mouse too?
Yeah. Yep.
Okay, cool. Because I forgot to label, this is the posterior mitral valve leaflet,
Yep.
and then this one's anterior mitral valve leaflet.
Definitely.
And then left ventricle, aorta, and right ventricle.
Good.
That's about all my knowledge.
So this would be like our long axis view transthoracic. So if we kind of flip it to transthoracic, this would be your right coronary cusp and your non-coronary cusp.
This one would be right coronary cusp.
Yep.
And then okay, that makes sense. All right. Are you guys good? Do you want to like draw that or do you want me to just keep going? All right, I'm going to keep going. Then I had esophageal aortic valve, short axis. This is 30 to 60 degrees. So obviously you can see the aortic valve super well. The right coronary cusp is on the bottom, and then the non-coronary cusp, and then the left coronary cusp. You can also see the left atrium and the right atrium, and then the outflow tract of the right ventricle, just the pulmonic valve.
Good. Yeah, and I like to use the intraatrial septum as my landmark for non-coronary cusp too. So that's good.
Oh, that's a good, okay, I like that.
If you're able to see the intraatrial septum, that's going to be along your non-coronary cusp. And then right, yep, and left.
Cool.
Cool. Very good.
And then I had also transgastric right ventricle inflow, which is at 100 to 120 degrees. So you can obviously see the tricuspid valve super well. And I tried to draw my little chordae.
Yeah.
So you got the right atrium and then the right ventricle and your little tricuspid valve. Do you want to add anything to that, Dan?
No, it's good.
All right. And then my last one was upper esophageal aortic arch, short axis, 90-degree angle. So you can see your aortic arch, and then your little worm is your innominate vein, and then your pulmonary artery and the pulmonic valve.
Nice. Yeah. So the only thing that I would add is these upper esophageal views. This is when you're going to be imaging your aorta, your proximal ascending, descending, and arch. So your aortic views will typically come from your upper esophageal level.
All right, I'm gonna write that down.
For registry.
All right, cool. I'll stop sharing.
Good drawings.
Thanks. Tried so hard.
You should send that to us.
You said what?
I said, can you send that to us?
Yeah.
Thank you. I can't draw that fast.
No, I didn't. That's why I was like, I'm not sure if you want me to like stop or if you want to just like get it later. I'll email it to you.
Well, it's all recorded, so you could.
That's a good point.
Oh, true. I didn't think of that. Okay, yeah, never mind.
All right.
I mean, I can go next, but I don't know how to share my
Go
screen.
ahead, Miriam.
Is it like share content? Is that what it is?
Or at the bottom, mine was like a green arrow and it says share screen.
No,
Okay.
you disappeared.
Hold on. Okay, so let me if you want to go, Alina, I just have to upload the pictures to be able to share it with the.
It's okay.
You can wait. I'm not.
I don't have it even on the PowerPoint. I just draw them all
That's
night
okay.
last night.
That's okay.
Hold them up. Be proud.
Okay, so I think I have it. Okay. Can you guys see that?
Yeah, girl. Look at your shading.
Yeah, so the first view that I had was the mid esophageal.
I can do this.
Oh, it's with my Apple Pencil. It's like, it was like super easy. I
Okay.
just basically traced it.
Esophageal bicaval.
Yeah, so in this view, you can see I wish I could like point to it, but you can see the inner atrial septum.
I think
The
we
left-
can see your mouse if you move your mouse on there, but I'm not sure.
Oh, I don't have a mouse. It's the
Okay,
I can move my mouse.
carry on.
screen. Yeah, so unless there's like a little thingy on here. No, okay, there's not. So on the top, you'll see the left atrial septa, or the left atrium, the inner atrial septa, and then you see the right atrium. On the sides, you're gonna see the superior vena cava and the inferior vena cava. And I didn't get the angles that they were taken at.
Let's see. Pretty sure I got all those angles. Cable is. That is 90 degrees to 110 degrees.
Okay. 90 degrees to 110. Okay. That's all I have for that one. Did you want to add anything, Dan?
So this is a good view if we're concerned for if the patient potentially has thrombus, right ventricular thrombus, if we want to see a source, or if we see thrombus within the right atria, like if a patient has renal cell carcinoma and we have thrombus invading, the IVC, we could potentially see this in this view. Also, patients that we're concerned about pulmonary embolism, we could potentially see, signs for right-sided heart strain, right atrial collapse, or potential thrombus within, the SVC or the IVC. So that's, good view to assess for that.
Okay. And then, oh, oops, I didn't mean to do that. Here. So then we have the mid-esophageal four-chamber view, which looks like the apical four-chamber view. The right atrium is visualized, the tricuspid valve, the right ventricle, the left atrium, the mitral valve. And I don't have the angles for that, for any of my images.
Four chamber is 0 to 10 degrees.
Okay, 0 to 10 degrees.
Four chamber.
Okay,
So that view, like our four chamber will give us a good view for reflux, assessing the mitral valve flow, looking for mitral stenosis.
okay. And I'm going to share the second one. Okay, so the next view was the upper esophageal ascending aorta. In this view, you're gonna see the right pulmonary artery. I'm trying to get the highlighter. The right pulmonary artery, the ascending aorta, and then you could see the pericardium.
The pericardium is like the bottom gray part. I know that's probably
Yeah.
a stupid question. Okay, cool.
No, girl, no stupid questions.
Where's my angle on that?
I got lazy with the shading on these two.
So
Okay. Do you want to add anything then, or should I move on?
Yeah, you can move on. I was just trying to find the angle. Where's the angle?
Okay. So the last image was the transgastric long axis view. You can see the left ventricle, the mitral valves, the aortic valves, the aortic root in the aorta, and then the right ventricle. And that's pretty much it for my images.
Good. So again, anterior mitral valve leaflet. That one, posterior mitral valve leaflet. The angle for the transgastric view is 120 to 140 for transgastric. I was trying to find the angle for that one, the pulmonary artery and the ascending aorta.
Is the posterior mitral valve leaflet the one closer to the aortic valve?
Yes.
Yes.
No, anterior. That's the anterior mitral valve leaflet.
Oh. Just kidding.
Yeah. So we're deep. So we're in that stomach angling back up, like kind of looking back up at the heart. So this is going to be posterior and this is going to be more anterior. Your
Okay, yeah.
ventricles on more.
Oh, okay. It confuses me when it flips.
Yeah, me too. Okay. That's all for me.
Do you have an upper esophageal angle, Dan, for ascending? That's okay if not. I think I had like a Google thing.
I think I took a picture too. Let me see if I have it.
Kind of looks like 90 degrees just based on the picture. Oh no, maybe a little less. So it looks like just descending aorta is 90 degrees. So that looks like. So it's not I'm just looking at like the picture that I've given you. I'd say that is it's a little more than 90. So that's I don't know, you want to say like 100 to 120? I'll look it up, but
Okay.
I'm just looking at the picture. So like descending like long axis, aortic long axis is 90 degrees, and then short axis is 0 degrees or 0 to 10. Like if I go, let me share my screen. Share screen. So like if I go to like our views and you see like the little angle here. So if when I search this one, it says 90 degrees. So like you see your little angle marker here. So that's 90 degrees. This is 0 degrees. So I was looking at hers. It's like a little past 90. So 180 would be on this side. Like this says 0 to 20 degrees for this one.
Oh, I think I found it. I think it says 100 to 150.
100 to 150. Okay.
Does that make sense?
Yeah. So I was going to go with 100, like it's just past that 90 degrees. So I was going to say like 100 to 120, but so you're finding 100 to 150.
Yeah.
Okay. I buy that. It's definitely past 90. So I would say like 100.
At least 100.
At least 100. But you know what? I have to ask this when the second years take their test, if they actually have the angle degree rotation as part of their boards, because you're not operating the probe and getting the angles. Like it's the doctor that's really turning all the angles. So
Right.
I want to see if they actually ask that on the boards coming up. So like I've been like getting all their knowledge from them. They had a lot of questions for vascular about pseudo aneurysm injection, like as a procedure. So they had some questions about that, like thrombin injections for pseudo aneurysms. That was like their big takeaway. It was like, oh my God, it was like procedures and stuff like for vascular. I was like, okay. A lot of procedure questions. All right. Stop share, sorry.
Mhm.
All right.
Okay, then I don't have a PowerPoint, but I draw
Okay,
everything
that's-
like this.
I can
that's
see that
beautiful.
fine.
See?
That's
we see
good.
that
Yeah,
fine. It's
I can
perfect.
see that.
So
Beautiful, yeah.
like this. So this is esophageal ascending aorta short view. So the transducer rotation will be 0 to 30 degrees. So on this view, we see right pulmonary artery, superior vena cava, and ascending aorta. And I believe the main purpose of this view is to assess the pulmonary artery. So the next image, guys, can you see it?
Yeah, beautiful.
It's transgastric two-chamber view with transducer position 90 to 110 degrees. So we can see here left ventricle, left atrium, left atrial appendage, and the mitral valve anterior leaflet. So this view is very good for left ventricular systolic function assessment, mitral valve subvalvular apparatus assessment, and mitral valve pathology, because it gives such a good portion of the mitral valve on this view.
Nice.
In esophageal two-chamber view, rotation position of the transducer 80 to 100 degrees. So here we can see left atrium, left ventricle. This is left atrial appendage. This would be anterior wall, posterior wall, coronary sinus. This is mitral valve anterior leaflet and posterior. So this view is good for assessing left atrial appendage mass and thrombus, because we can see it here. Left ventricle systolic function, left atrium pathology, left atrium apex pathology, and mitral valve pathology.
You said that was 80 to 100, right?
Yes.
Okay, cool. Just checking.
So, and the last two I have
Yeah, way
is
better than mine.
aortic valve in long view, metaesophageal aortic valve long view.
Nice.
So it reminds us our parasternal lung, but we
Yeah.
can see it better here with the right coronary cusp, non-coronary cusp. And in some slides, it was non-coronary or left, so which was a little bit confusing, but it's non-coronary or left.
Yeah. you
Left
can take
ventricle,
A little
left-
rotation will give you that.
Yeah, because it's 3, and here we see kind of 2.
Yep.
So we have mitral valve leaflets, posterior, anterior, left atrium, left ventricle, aorta, ascending aorta, and right ventricle. So this view is good for aortic valve pathology, aortic root dimensions, LVOT pathology, and ventricle septal defects. Okay. All right, this is all I have.
Good. Oh, good job, everyone.
I can scan it, I mean,
No, you don't have to.
and do the PowerPoint.
No,
and,
no,
No,
you
no,
don't
that's
have-
okay.
No,
Because we're
And-
recording, so we can
we're
just like
recording.
freeze it. Yeah.
Yeah,
Yeah.
that's good. So that concludes Echo 112, right? I know,
Yay.
right? We can do a little review for the.
yes, we,
final.
mhm.
Sound good?
Mhm.
Means we need to know everything.
Everything.
I don't even know what I need help on.
I know, same. I feel like I'm trying to focus right now on like vascular and physics just because Echo's like the last one that we're taking.
Last one, yeah. I think that's.
And then physics,
Physics and vascular, everyone seemed to be like freaking
Yeah.
out about, especially physics.
mhm.
Let's minimize that. That. Let's see, what we got on here that you guys may not remember.
Are you looking at our final right
I
now?
am.
I wish we could just read your brain.
Well, I'm gonna help you guys through it. See, this is what I'm gonna be doing kind of with vascular too. Like, I'm going through the file, I'm like, all right, what don't they probably know? And touching on those. All right, so some of the prosthetic valves, I know there's some questions on prosthetic valves. So autograft. Homograft. So what's the difference between the two? Or what's the same about the both of them?
They're both from human tissue.
Both from human tissue, good. So what's an autograft?
From
an-
patient's tissue, from his own tissue, I mean, her own
Your own,
tissue.
yeah, so valve
Oh,
comes from patient, I guess when I say from the same person. So the valve, so it's your own, we'll put that, your own valve. And autograph, I would associate you with that Ross procedure. Ross or Ross, right? Ross, yep, Ross procedure. Homograft comes from a donor, a human donor, comes from human donor.
Is the Ross procedure like specifically when the pulmonic valve is resected?
Yes.
Okay.
So with that, you're removing the pulmonic valve and transplanting it in place of the aortic valve. And then you're now placing a stent with the valve into the right ventricle. So Ross procedure removal valve. And placing into the aortic valve. Placing and valve RV. So bioprosthetic versus mechanical. So what do we know about the differences between the two? Mechanical valves, they last longer.
But the patient needs to take blood thinners.
Yep, require anticoagulation.
Anticoagulation.
Some disadvantages also. So more stenotic, more
Regurgitant.
regurgitant, exactly. Issues with shadowing, which limits assessment. So our three main we'll erase this for a second. So our three main mechanical valves. You have the wall and cage. This is your Star Edwards. Mechanical. Wall and cage, Star Edwards. This is going to be your most stenotic slash regurgitant. We're also going to put, it's not used anymore. So these patients are becoming fewer and fewer, you know, it's less and less common that you're going to encounter this particular valve as the patient population ages. So not used currently. So by the time, you guys get maybe 10, 15 years into your career, you may never even see this valve anymore. So the next valve is going to be our single tilt disc. So this was an improvement on that first valve, that ball and cage, the Star Edwards valve. So this was, the ball and cage was the kind of our first attempt at creating primarily an aortic valve. And then technology advanced and we created this single tilt disc valve. That's when you have your valve with a single disc that opens and closes. So this is the Bjork Shiley.
Should we be able to like recognize pictures of them?
Not for the final now.
Okay, cool. Because I feel like I wouldn't. I actually saw a St. Jude one at CDC when I was there.
Oh yeah.
But honestly, I feel like I didn't see anything. I was like, I can't see anything.
So then we, as technology and our medical advances, we then came up with a bi-leaflet mechanical valve, and that's going to be your St. Jude. That's the most common. Leaflet. Common. Some other examples are Cargomedics, Duramedics. And these are going to be the least obstructive, the bi-leaflet. So least obstructive. So that's the mechanical valve of choice now, is your bi-leaflet mechanical valve. So bioprosthetic valves. So typically they're going to either be porcine from pig or bovine. So bioprosthetic. Be usually. Bovine. So from a pig or a cow. So the porcine valves are going to be your Carpenter Edwards. Carpenter Edwards. Or Hancock. So with bioprosthetic valves, there's little to no stenosis, regurg. So don't require anticoagulation. Disadvantages don't last long. Mechanical. And under bioprosthetic also typically used in pediatric patients.
Does stented and non-stented go under there too?
Yep,
I had that like in my notes, but I couldn't tell
Yes.
if it went under that or
yep, yeah, so that's, yeah,
Mechanical.
that's under bioprosthetic valves. So bioprosthetic valves are then, they're broken up into stented and non-stented. So basically the stent is a ring that's almost like an annulus that you're placing into the, with the valve as well. If you look at stented, we'll call that like the stented as, what do I want to say? Like, I don't want to say mechanical, but synthetic annulus. It's got a stent that's holding open, you know, that valve area. Whereas the non-stented are sewn directly into annulus. God, I spelled that wrong. Annulus. So this Carpenter Edwards, this one's actually gonna be a stented bioprosthetic valve. That's pretty. Let's see what else we got here. Right, I'll go a little bit into valves. All right, so if we have mitral regurgitation, we have to understand what's the heart's response going to be to stenosis and regurgitation. So if we have chronic MR, meaning it's a slow process happening, over time, this patient's had it for a long time. So heart's response is going to be left atrial dilatation. With left atrial compliance. So that means that the heart is able to kind of accommodate that extra volume and is learning to deal with it. So we get compliance to that increased volume. So patient may have little to no symptoms. So acute MR. So if we have MR as a result of, say, like a papillary muscle rupture, or if you have a cord that ruptures and all of a sudden now you have severe MR, or if the patient perhaps maybe developed a vegetation that's now causing acute or sudden onset of mitral regurgitation. Patient will exhibit significant symptoms. Patient will have pulmonary hypertension, and pulmonary congestion. So mitral valve stenosis. So heart's response for mitral valve stenosis is going to be left atrial dilatation. Increased left atrial pressure. It could eventually back up to the pulmonary vascular bed, so pulmonary congestion. Pulmonary hypertension. Mitral stenosis can also lead to left atrial thrombus. So aortic valve disease. So the most common causes of aortic valve disease in adults. It's going to be the common causes. Adults have degenerative. That valve is breaking down over time. You know, it's under a lot of stress. The aortic valve, it's got to withhold those pressures. So the main thing that affects the aortic valve is going to be degenerative changes. We can also have rheumatic disease. As well as infective disease. Be your endocarditis. So in terms of aortic valve disease, for aortic stenosis, let's see. Valve area. Gonna be less than 1 centimeter squared. For severe stenosis. Velocity. Greater than 4 meters per second. Here. Heart's response. Is hypertrophy. Followed by dilatation. So aortic stenosis is considered a pressure overload. So it could also be considered something that can affect afterload. Afterload is affected. So we remember the difference between afterload and preload. So preload is anything that affects the volume of blood in the ventricles prior to systole. So it's the end diastolic volume of blood in the ventricles. And then afterload is anything against which the heart, has to work against to eject the blood from the ventricles. We talked about preload and afterload. Afterload, would be stenotic pulmonic valve and aortic valves, systemic hypertension, pulmonary hypertension. Afterload could be coarctation of the aorta. Afterload, when we learned, it could also be potentially a dissection. I think so. Things that affect preload would be aortic insufficiency. Things that can affect preload would be also valvular insufficiency or regurgitation on the mitral and tricuspid valves. Preload could also be fluid volume. So if the patient has fluid overload and it's increased blood volume, or potentially anemic and have a low blood volume. So for aortic regurgitation, This is considered a volume overload, so the heart's response to a volume overload for the left ventricle is going to be dilatation followed by hypertrophy. So it's going to dilate first and then hypertrophy. I overload. Response dilatation. And hypertrophy. So LVOT structure. So things that we know about LVOT obstruction. Doppler tracing. Dagger shape. Due to delayed acceleration. Blood through LVOT and aortic valve. So essentially, it's almost, I don't want to say like a TARDIS Parvis waveform, but it's the same kind of principle that because of that obstruction, we're getting a slow increase to our peak maximum velocity and gives it a dagger shaped appearance because of that obstruction. So it's really relying, like once the aortic valve opens, we're not getting that nice, quick acceleration of forward flow of blood through the LVOT and the aortic valve because of the obstruction. So it's really relying on the contraction of that heart, to really squeeze all that blood out. So that's what we're seeing is that delayed, systolic increase of velocity with the LVOT obstruction because it's relying more on the contraction of the heart rather than the sudden pressure change when that valve opens to accelerate that blood through the valve. Know some of your, be familiar with some of your wall segments for your coronary artery vessels. So like some of the major ones. So if we draw like our apical two-chamber view. Do you know your wall segments? Like which side of the wall is that? Anyone wanna?
Inferior? I don't know.
Oh no, oh no. We know this. We're gonna pull this up. All right. Oh, you got it. Inferior and anterior. Oh, lost you.
In the blue workbook, they have the wall segments in there
Oh, there you
on
go.
page 1.
Yep.
You guys wanted to use that.
So inferior, anterior. So inferior, we know is going to be our which coronary artery?
LAD?
For inferior? Right.
Dan, stop asking me questions. I don't know.
No, so anything in the back of the heart, inferior, posterior, you're gonna want to think the right coronary artery. Anything like anterior front of the heart, majority of the left ventricle, like the apex is gonna be your left anterior descending. So front of the heart, anterior segments, a good portion of like your anterolateral segments are all going to be LAD. And anything inferior, posterior, right side of the heart, it's going to be your right coronary artery.
All right, I'll get the next one.
You'll get the next one. So also too, there's going to be in like your four-chamber, there's going to be a segment of that basal septal wall. That's going to be your right coronary artery. I know they like. I'm dying to find out like if they're going to throw them a video clip of that on the registry. Like I remember that, you know, they always had a clip with like a akinetic basal septal wall in your four chamber view, and they want you to, you know, recognize that's the right coronary artery. So then for this segment, when the apex is going to be our LAD. And then this segment is typically going to be left circumflex slash LAD. It's going to be lateral. This is inferoseptal. That way. I guess another way to try and also remember your wall segments too is where your notch on the probe is as well. So for us, like I know when we're doing our apical four chamber view, kind of think like, you know, like which side of the screen is going to be your notch. So if we're in our four chamber or notch, you know, it's going to be down. Like on our heart and the patient's lying there. It's kind of hard to, I guess, picture in four chamber. Trying to think what other segments we need to know.
I know Kate used to say like in for like inferior and anterior. So you know like inferior is like first and then like anterior. So that's usually how I remember just inferior and anteriors in and then like the septal, I'm like, all right, well, that's kind of easy because it's like on the
Basal,
septum.
Yeah. Yeah. So I mean, yeah, basal septal, mid septal,
Apical.
apical. Yeah. Do we know what Epstein's anomaly is?
Displaced tricuspid valve.
Yep. And it's displaced basal or apical?
Apical.
Apical, good.
Thanks,
Apical
Elena.
displacement of the tricuspid valve. And which view would we see that best on?
Apical
Yeah, apical
Oh.
four chamber.
four chamber.
Yep. So we'd see our tricuspid valve up here. That's your Epstein's anomaly. Um, What was most common cause of mitral stenosis? I jumped over that actually. So mitral stenosis, what's the one thing we always
Rheumatic heart
Heart
disease.
disease.
That's
Mhm.
rheumatic heart disease, so that's always go hand in hand, mitral stenosis and rheumatic heart disease. That's gonna be our most common cause of mitral stenosis. Stenosis. Common cause, rheumatic heart disease. Disease, I'm just putting HD. You also call that stick. Appearance. Of Anterior mitral valve leaflet. Notice. Use continuity equation. To calculate valve area. Mitral stenosis, use pressure half time. Did you guys get a very nice handout that showed M mode pathology by any chance?
I kind of remember a packet, but I don't think I have it
I
anymore.
don't have it anymore. Because I was reviewing with the other class and they wanted stuff for M mode. And I went through like some of the binders and found a really nice handout that had like M mode pathology. Let's see, content. Mark, what did I just do?
Is the M mode pathology going to be on the final or like boards?
There's a couple on the final.
Oh, goody.
Oh, goody. That's my computer. So, um, content. All right, so I just put under week 13, like this M mode PDF document. So let me see. So particularly like some of these mitral valve and aortic ones, you should become familiar with. So like dilated cardiomyopathy, M mode findings. So you could see with like the increased EPSS, the double diamond appearance, and the B notch, which is number 3. The systolic anterior motion of that mitral valve leaflet, that's an M mode that you should definitely become familiar with. As well as the mitral valve prolapse M mode. So you could see when the leaflet should be closed and B1 and B2, you're getting, you're prolapsing of that mitral valve. This one, partial mid-diastolic closure of the aortic valve. That's an important one, due to the asymmetric septal hypertrophy, the idiopathic septal hypertrophy. Thanks. But this is a good reference too when you get into your boards and studying. So partial mid-systolic closure of aortic valve may be seen with septal hypertrophy due to sudden decrease in cardiac output. What would be the primary cause of hypertension? Anyone remember primary cause of hypertension? Could go back to that lecture. The primary cause of hypertension is going to be
Idiopathic.
Yeah. Another thing for aortic stenosis. So, stenosis could be subvalvular. Valvular. Or even post-valvular. So we can have, stenosis below the level of the valve in our LVOT. We can have valvular stenosis or even post-valvular.
How many questions are on the final?
75.
Oh, that's not terrible.
Oh,
We have 3. Is it like at the same time, like 12 to 3?
yeah,
Okay.
promise you, I don't think you guys are gonna, I'm just going through the questions. I was like, they know this, they know this. Um. The cardiomyopathies. So we're pretty good with the cardiomyopathies, I think.
Finally, took me like all year.
Like, what's the main cause of constrictive, constrictive or restrictive, sorry. Main cause of restrictive cardiomyopathy or infiltrative cardiomyopathy.
Amyloidosis?
Amyloidosis, yep. So with restrictive cardiomyopathy, main thing we see is biatrial enlargement. We have normal systolic function, but abnormal diastolic function. So we have abnormal ventricular filling. The ventricles are stiff, they can't expand, but we are able to contract the ventricles. So with restrictive cardiomyopathy, myocardium. So remember that too with the cardiomyopathies, this affects the myocardium. So it's a disease process which affects the myocardium that is not related to an issue with the valves or related to, cardiac coronary artery disease. So these are conditions unto themselves that affect the myocardium. So we have stiff myocardium, which creates diastolic dysfunction. Amyloid. I spell amyloidosis. I'm the worst at spelling.
I think it's AMY.
AM. That looks right.
We know what you mean.
Amyloidosis. cause. Secondary, or not secondary, but like other potential things. Maybe sarcoidosis would be another infective process which can affect the myocardium. We can put under amyloidosis that ground glass appearance. Sometimes it refers to as speckled. They have a speckled appearance. You know, our features are going to be biatrial enlargement. And we know that we have to differentiate between restrictive cardiomyopathy and constrictive pericarditis. So in the names right there, the constrictive pericarditis is the pericardium is now thickened, echogenic, non-compliant, stiff. Whereas the restrictive cardiomyopathy is the myocardium, which is the issue. Constrictive pericarditis, we typically will not have that biatrial enlargement. The atrium may be relatively normal in size. With restrictive cardiomyopathy, mitral and cuspid regurg is usually present. Our prognostic indicators for restrictive cardiomyopathy is the degree of regurgitation, the degree of diastolic dysfunction, our atrial pressures. So restrictive cardiomyopathy, we also worry about atrial thrombus. Hypertrophic. Most common form of hypertrophic cardiomyopathy is asymmetric septal hypertrophy. So with our asymmetric septal hypertrophy, so this is associated LVOT obstruction. Our, Ash, I'm sorry, Sam, systolic anterior motion. The mitral valve leaflet. You can also have eccentric LVH. And that's typically not associated. LVOT obstruction. Not associated. Apical hypertrophy. This is more common amongst Asian population. What else we need to know? Our treatment for this would be our ablation or alcohol ablation. Then we know for our dilated cardiomyopathy, that's going to be our big dilated leaky heart. Some key terms that are associated with your dilated cardiomyopathy is that the heart begins to take on a more spherical shape. That's why we have that spherical index calculation that some labs will do. Cardiomyopathy. Large. With reduced systolic That's going to be our definition for dilated cardiomyopathy, the large dilated ventricles with reduced systolic function. Secondary. Dilated atria. Mitral and tricuspid regurg. increased. Increased left atrial pressure. Tension. These patients require typically require biventricular pacing devices as treatment. But these are usually just a bridge to cardiac like heart replacement surgery or pacing. So the reason we get, the mitral regurg and the tricuspid regurg is because as the heart's dilating, the valves aren't able to co-opt properly, so the annuluses are being stretched further and further apart. So as the heart dilates more, the regurgitation gets more or increases, and it just kind of all starts snowballing on you. So the more it dilates, the more it stretches, the more regurg you have, which leads to more stretching. So those regurgitant jets are typically central jets as opposed to eccentric jets guided towards the wall. So those jets are typically in the center of the chamber. We said with dilated cardiomyopathy, the heart takes on a more spherical shape. Guess just real quick about wall thickness for the heart. So greater than 13 millimeters is considered a thickened cardiac wall. So for wall thickness, greater than 13 millimeters is Shared. Again. Any questions like about some of the other stuff? Like I'm just kind of looking through the test. I feel like you guys know a lot of this stuff. Like resting blood, like in terms of coronary artery stenosis. Like, artery stenosis requires a blockage greater 90% at best. Cause cardial motion abnormalities. So that's why we exercise the patients and do the stress tests to try and unmask these high-grade stenoses and blockages in the coronary arteries. Because if a patient's just resting normal, they can have a very significant blockage in that coronary artery and we'll never know it.
TEE is gonna be on the final.
Those views, no,
Okay, cool.
that
We're
was
just
fine.
like
No TE,
prepping.
no,
Just making sure.
no. That was just for us to learn and we had a little extra time here at the end, so. Did you, I don't know, aortic dissection, should I talk about that?
Sure.
Sure. So we know aortic dissection is a separation of the intimal and medial layers.
Then there was a question about transaction on our test. So is it caused by trauma?
Yes,
Okay.
a blunt trauma to the chest. So yeah, transection is basically like separation. Yeah,
Caused by like a force
yeah,
out
blunt
from
trauma.
outside
So, like,
force.
most of the time you'll see those will be your motor vehicle accidents, your MVAs, you know, from that seatbelt coming across or hitting the dashboard. So with dissection, you'll have your true and your false lumen. So I don't know, we'll just whatever. I kind of drew this the wrong way. We're doing the arch. We have blood flow going up the arch. We'll have blood entering our lumen. So this will be our false lumen. We'll have blood continuing in the arch in our true lumen. So in the false lumen, we could potentially see bidirectional flow. In false lumen, you could potentially see bidirectional flow. That's because the blood's going in and it's hitting, you know, the end of that dissection and then reversing back. So during systole, we'll get red. During diastole, the blood flow will try and return back out of that false lumen. So we could potentially see bidirectional flow. In the false lumen, we could potentially also see smoke. So there could be stasis of that blood flow within that false lumen. We could potentially also see thrombus within the false lumen. So in the true lumen, we maintain forward flow. The true lumen is typically oval or spherical. So if we turn it transverse on that vessel, we'll typically maintain an oval, circular, spherical shape. The true lumen will expand during systole. It's usually the larger of the two.
I thought, oh, I don't know. I thought true was smaller.
Smaller.
I mean, I'm probably wrong, but that's what I put on the quiz.
True is smaller.
I can go back to the PowerPoint.
Maybe.
I don't know, Dan. Don't take my word for it. Hold on.
True might be
No, true
smaller.
is smaller.
Small of the two.
Yes, sorry. Oh, my bad. True is smaller of the two.
The only reason I remember is because I like just read it. But then I was like, maybe I'm wrong.
No, no, you're right. It's because the thrombus formation. Or you guys also know that valvular disease of the right side of the heart, like the pulmonic and tricuspid, is usually congenital in nature. That's usually a result of congenital heart disease. One of these questions is real funny. That's all right. It's like the
What do you mean
choices-
funny?
Hopefully it's easy funny.
It is easy
Yeah.
funny. It's like, it's like seriously. Talks about where you get tissue for a bioprosthetic valve. Like, oh my God. It's just funny. Like, who came up with this test?
So you didn't make this test.
I didn't make the test. It was, it's from the bank of tests that I have been instructed to give. All these tests, like there's folders of like exams that I'm supposed to alternate like year to year. So like, it's just funny. I mean, it's like the same general type of questions, but like they're not exact, like, so because they don't want like, one class question dumping on the other class. And so at least you've graduated by the time this test comes up for the next class. So 2 years down the road.
Right. It would be good if they're somewhat similar to board exam questions. Like,
Yeah,
no, not so funny, but to the
Yeah.
point, because
yeah.
we don't want them,
No, I know it to be like, a waste of time.
to meet something. I mean,
No, I
come across
get you.
something totally different.
Yeah. I think they're pretty similar to, well, the main points, yeah, like, it's just that one question's a little silly. That's not really silly. I mean, you have to understand, like, where you get tissue from.
But maybe it's how they made the test. Some questions are like ridiculously simple, but then some of them very kind of complicated.
Yeah,
And difficult.
So we know about spontaneous echo contrast in the left atria. It's a precursor to thrombus formation. Discuss that, discuss that. I got a good idea. Let me get my registry review book. Let's see if we can answer some of those questions. Let's see, what is the best two-dimensional echo view for Doppler analysis of mitral valve flow? So choice parasternal long axis, parasternal short axis, apical 4-chamber, or apical 5-chamber, or subcostal 4-chamber. So the best view for doing mitral valve flow analysis. Doppler
4-chamber?
analysis.
Apical 4.
4, yep. The mitral valve opens when the pressure in the left atrium exceeds the pressure in the left ventricle. The
Yes.
pressure,
Yeah, that's what I was gonna say. Yeah. True.
true. Yeah, the other options were like pressure in left ventricle exceeds the pressure in the left atria, which is no. Pressure in the right atria, no, that's nothing to do with the right side. What does the A wave represent in the pulmonary vein Doppler waveform? So blood flow in the atrial annular with blood flow with atrial annular motion, blood flow with the atrial contraction, blood flow with atrial regurgitation, blood flow with mitral early inflow, or blood flow with pulmonary artery regurgitation. Yeah, that's, we can go over like pulmonary vein waveform.
Yeah, I don't
Remember
think
the
I know.
pulmonary vein waveform, like it was SD and A, like your waves. So the A wave was actually below the baseline, and that was the atrial kick. So when the atria contract. It's kind of your pulmonary vein waveform. Oh, sorry. I gave this guy disease. We'll make the S one smaller. than D one. So S represents systole, D represents diastole, and then A is when the atria contract. You know, isovolumic relaxation and contraction. Which of the following best describes the appearance of a ventricular aneurysm? We have a chronic contained ventricular rupture, a hole between the two ventricles due to ischemia, a hyperdynamic left ventricular wall with exaggerated systolic contour, a dyskinetic region with abnormal contour, laminated thrombus along the ventricular wall. So ventricular aneurysm. So that's when we have a wall that's become dyskinetic, a region of dyskinetic with abnormal contour. So we consider that ventricular wall aneurysmal. A chronic contained ventricular rupture would be more describing a pseudoaneurysm. A hole between the two ventricles due to ischemia would also be a potential like ventricular rupture. With aneurysms, the heart's not going to be hyperdynamic. And then thrombus would be thrombus. So which of the following best describes a pseudoaneurysm? That would be a contained ventricular rupture. Again, a hole between two ventricles due to ischemia, hyperdynamic left ventricular wall with an exaggerated systolic contour. A dyskinetic region with abnormal diastolic contour.
The first one?
Yep, the contained ventricular rupture. Yep. Which of the following conditions is associated with aortic aneurysms? You have Epstein's anomaly, Down syndrome, hypotension, or Marfan syndrome.
Marfan.
Marfan's, yeah. And these are like registry book questions. What is an aortic dissection? And it has like a focal dilatation of the aorta greater than 4 centimeters. A focal area of inflammation with visible calcification, a tear in the intima that creates a false lumen.
That one.
Yep, focal dilatation of the sinus of Valsalva. So,
How many questions are on the registry?
120, I believe 120 or 150, I forgot.
For 2 hours.
I believe you get 3.
Okay.
I thought it was like a minute per question. But I could be wrong. Because I remember Donna saying that, like, oh, that her tests are only a minute per question because that's how the board exams are.
It's only 2 hours. I'll ask them. They got 2 hours or 3 hours.
Yeah.
Which of the following echocardiographic findings would be associated with aortic dissection? So we have an aortic valve area of 1 centimeter squared, a left ventricular outflow tract diameter of 1.8 centimeters, a left ventricular wall measurement of 5 millimeters, wall motion abnormalities associated with obstruction of the right coronary artery territory, or aortic stenosis.
I feel like
I'd guess the wall motion one, but I don't know.
I would agree with you. Let's see, 122. Yes, wall motion abnormalities associated with obstruction of the right coronary artery territory. So that dissection now tears off the intimal wall, is now covering the right sinus of Valsalva and not allowing blood flow into the right sinus, and which causes, you know, the wall motion abnormality because blood flow is not getting into that right coronary artery due to that dissection. Not good. So you can break these down. Which pathology is a complication associated with complex aortic plaques? We have deep vein thrombosis, decreased ejection fraction, peripheral arterial embolism, pulmonary embolism.
Peripheral embolism?
Of course, yeah, aorta. So it's not.
Of course. You're like, duh.
No, well, if you think about aorta, like it's not going to be anything with the lungs. It's not going to be pulmonary related. And like, how is that plaque going to break off and go to the lungs if you're in the aorta?
The
So it's
hand
gonna
of
go-
God.
Yeah, it's, well, that'd be terrible. So yeah, so it would be peripheral arterial embolism. If they had put stroke on there, that could potentially be one too, but it's not going to be DVT. It's not going to decrease your ejection fraction, you know. The sinus of Valsalva aneurysm in the right coronary sinus usually protrudes into the left atria, left ventricle, right atria, or right ventricle.
Right atria?
Left ventricle? Right atrium. A sinus, wait. A sinus of Valsalva aneurysm. I'm changing mine to left atrium. Sinus of Valsalva. Somewhere on the left side.
Right sinus of Valsalva aneurysm usually protrudes.
Wait, right side? I don't know. I'm confusing myself. Elena, you said right
Mhm.
Yeah,
ventricle.
right ventricle. Yeah. So actually go back to that when Elena drew her beautiful short axis picture, we saw like a picture of the right ventricle and the right coronary sinus, the right coronary cusp, like is seen along that right ventricle. Like, I think she had like a beautiful picture of it.
So it's right, right?
Yeah, that's right. Yep. I mean, these are all types of questions. So causes of aortic regurgitation include all of the following except. So we have Marfan syndrome, bicuspid aortic valve, Epstein's anomaly, rheumatic heart disease, and endocarditis. So causes of aortic regurgitation include all the following except Marfan's, bicuspid aortic valve, Epstein's anomaly, rheumatic heart disease, or endocarditis.
Epstein's?
Epstein's, of course.
Because that's the right.
Yep, tricuspid valve, yeah. Which of the following, which is one of the following first two-dimensional image findings associated with aortic regurgitation? So for aortic regurgitation, we have thickened aortic valve, left atrial enlargement, left ventricular enlargement, or left ventricular hypertrophy.
What was it? All of them except, what was the
So
question?
which one of the following is which one of which of the following is one of the first two-dimensional imaging findings associated with aortic regurgitation? So what's one of the first findings that we'll see with aortic regurgitation? Thickened aortic valve, left atrial enlargement, left ventricular enlargement, left ventricular hypertrophy.
Second valve, maybe?
Yeah, I was gonna say left ventricular enlargement or LVH. I was between them.
Yeah, so it's going to be left ventricular enlargement. So with regurgitation, it's a volume overload. So the heart's response is going to be dilatation, left ventricular dilatation, followed by hypertrophy. So it's going to dilate first and then become hypertrophic. Or if it's a pressure overload, the response is going to be hypertrophy first, followed by dilatation afterwards. So aortic stenosis is a pressure overload. So heart's response first is going to be hypertrophy, followed by dilatation. With regurgitation, it's going to be a volume overload. So the heart's response is going to be dilatation, followed by hypertrophy. So it's going to dilate first because it's a volume issue. So pressure issues for the ventricles, they're going to hypertrophy, build those muscles to fight that pressure. With volume issues, the heart's going to try and expand first. The ventricles will expand first to try and accommodate for that extra volume. And then it's going to hypertrophy. Then this summer, I think I'm gonna do a lot of images. So I'm gonna try and do some quizzes with pictures, so we can get used to looking at pictures and reading pictures. Cause I think you guys are, I mean, just some of this, I mean, it makes sense, like what you guys are telling me. As long as you can try and kind of break it down. Again, here's another, the most common cause of aortic stenosis in adults over 65 is, so we have bicuspid aortic valve, aortic sclerosis, traumatic disease, or lupus valvulitis. I've never even heard of that one. So we said that aortic stenosis,
Sclerosis.
yeah, so it's gonna be degenerative, so aortic sclerosis, yeah. Yep, aortic sclerosis. The heart murmur associated with aortic regurgitation is called, so your choices are a pansystolic murmur, opening snap murmur, blowing early diastolic murmur, or systolic ejection murmur with crescendo decrescendo. Sounds like opera.
Blowing one.
Yep. Why?
Well, I was pretty sure it was gonna be a diastolic one.
Exactly.
So
No, that's
I
exactly it.
was
It's
just
it's the only
going off.
option that gave you anything that had to do with diastole. That's exactly how you have to break these questions down with these murmurs. Is it a systolic murmur or is it a diastolic murmur? You know, and that you're most likely going to be able to answer the question that way.
Morgan, you're able to take the board exam right now, girl.
I'm at like a 70, but I guess that's passing. I feel like Elena's good at like the really, really hard ones that I'm just like,
Oh, come on.
what?
Anyway, yeah. So next summer we're gonna start doing pictures like
Oof.
these. Yeah, we're gonna need to like get used to looking at pictures now and then diagnosing off pictures and clips.
Yeah, I feel like that'll be really useful for
Then
clinical.
like then your cardiac tumors. These always show up in the register. What is the most common primary cardiac malignancy? Primary cardiac malignancy, most common.
Malignancy.
Most common primary cardiac malignant tumor.
Angiosarcoma.
Yep,
Yeah.
angiosarcoma. Second most common, remember?
Rado,
Yeah.
rad, whatever.
Leiomyosarcoma. Most common benign cardiac.
Myxoma.
Yep. Most common tumor which affects the valves. Primary cardiac tumor affecting the valves.
Fibroelastoma.
That's 3 board questions right there that are most likely going to be on your boards.
All right, we got a 3%.
3%.
Does writing your name count like on the SAT?
Oh God.
Why? They see if you misspelled the name?
I
On
think they,
SATs apparently. Do they still do that? Give you credit for writing your name?
they give you like 10 points, I want to say,
Writing your
For,
name.
for ability to spell your name, right?
for spelling your name and like making sure you wrote it. and-
That's gotta drive you crazy, huh, Elena? They're coming from, I know people who come from other countries and they see all these multiple choice questions and all this bonus points and like the way education is in other countries. Like I was talking with Karima, she's like, multiple choice? Like, are you kidding me? Like, we have to write our answers and explain our answers and we don't get credit if we don't write it out, like multiple choice.
But sometimes it's even harder because they can be tricky, like
Yeah, the
two,
wording, I
5,
guess.
yeah, like 2 by 2 is what? It's 5, it's 6, it's 7, it's 8. And
Right.
sometimes like there is no 4 in the answer and you're sitting like, oh my God, and you have to pick up the closest or next right one or something like that.
All right. Well, that's it. I gotta get ready for now for vascular review.
Yay,
All
switch
right,
gears.
then, see you.
Cheers. All right.
Thanks, guys. See you in half an hour.
See you.
See ya.
Then I'm not gonna be here, but I will check the
Yeah, check
posted
the recording.
review.
Yep. Bye.
All right, see you Tuesday. I guess.